Dr. David, welcome.
Oh, thank you. Thank you. Can you hear me and see me okay today?
Clearly, very clearly.
Wonderful. And
Very,
Shashi and Anoop, thank you so much for inviting me to be involved in your important meeting today.
yeah, thank you. Thank you for coming, accepting our invite, and let me put on record your 2019 tweet. Thank you for that great tweet, which you had mentioned about dlive.in as being, best for Indians. So over to Shashi now.
You
Yeah, so
certainly
I think
deserve all the accolades and the tweets.
so welcome to all the viewers. Me and Anup, of course, we are hosting this historic and scientific feast for India. Anup is, of course, the originator of D Life, the only oldest, biggest, and the only award-winning low carb platform. So we have a special guest today, Dr. David Diamond. Let me briefly introduce Dr. David Diamond. So he has received his PhD in biology in 1985 from the University of California, Irvine, with a specialization in neuroscience. He recently retired as a career scientist in the Department of Veteran Affairs after almost 30 years of service, and currently a professor in the Department of Psychology, Cognitive, Neural, and Social Science Division at the University of South Florida. Dr. Diamond has been funded by VA, NIH, DoD, NSF, and the pharmaceutical company for his neuroscience research with over 150 publications, reviews, and book chapter. In the recent decade, Dr. Diamond has expanded his research program to address the controversial issue, including involving the cardiovascular disease and the nutrition, with publication in peer-reviewed medical journals. In recognition of the importance of his work to the global healthcare, he has been invited to present his research at numerous domestic and international nutrition, cardiology, obesity, and diabetes meetings. He has delivered lecture with over 1 million views addressing how the public and healthcare workers has been misinformed about the purported risk of high serum cholesterol and the appearance of a substantial benefit of medications that lower cholesterol. So welcome again, David. David, how would you like to
Thank you.
proceed? Would you like to start with slides or how is it?
Well, I always like to use visuals because you can tell people about the data
Hmm.
and the findings. But I think when you see the visuals, you see the graphs, and you see actually how we've been deceived about the fears about the cholesterol.
Yeah.
It's far more effective. So if I might, I hope
Please,
it'll work for my PowerPoint
it will
to
work.
come
It
up.
will work. You can share screen. It will work.
Okay, so let's
Just
share
open
my
the slide,
screen.
share screen, and it will do. It has been enabled.
Well, let's see, screen two. No, screen one. Okay. And let's go to my PowerPoint.
Yeah.
All right, how does that look?
Yeah. Fantastic. You can start.
Okay, great. So this is actually a title from when I was at Low Carb Denver. So if people want more information, this talk was recorded. This was from a year ago. So we got a lot to cover. This slide, which I hope you can see, shows my triglycerides were astronomically high. This is about 25 years ago, and in which you're hovering around 800, and my HDL was in the low 30s. So my triglyceride HDL ratio was extremely frightening at about 23, which is more than 10 times what is recommended to people, maybe even 20 times what is recommended. And as you said, I'm a neuroscientist. I've been a neuroscientist for over 40 years. But when my doctor told me I was at such a high risk for developing heart disease, it really was alarming. And he recommended that I go on a variety of medications, including statins. And you can see all over here, there are the warnings to me from that are in my notes that the patient, is he agreeable to go on medication? And what I decided to do as a scientist was learn for myself. And so you could see here that in fact, it's very frightening to hear about hypercholesterolemia. And so in this slide, you've got these cholesterol crystals that actually are in the artery wall. And so you see here is something straight from 1951 in which this high cholesterol is associated with premature mortality. And this has continued to the present day. When I started reading about this, in which I had not only extremely high triglycerides, I learned also that I had extremely high cholesterol. And so you can see that someone in his 40s now with very high cholesterol can expect to have a cardiovascular event or even die. So this was very frightening to me. But again, as a scientist, I wanted to learn more about it. And so what I found in the literature is completely contrary to what you'll hear from cardiologists and what's taught in medical school. And so this is a very important finding, and it's consistent with many other publications in which people diagnose what's called familial hypercholesterolemia, meaning they have extremely high cholesterol from birth as a result of considered a defect in their cholesterol receptor. And so when you look at the rate of death, which here the general population here is 1.0. So if you're above that, you're dying at a higher rate than the general population. And so it's frightening when someone who is a teenager or in his 20s dies of heart disease when this is almost unheard of. And so your first two bars are above the baseline for the population. But what's important is that this is not statistically significant, that only a subset of the people with extremely high cholesterol die at a higher rate than the general population. And overall, these people are not actually dying at a higher rate than the general population when they are young. And now look at what is happening as they are getting older. These people, supposedly with this lethal disease, are dying at a lower rate than the general population. As you follow those blue bars downward, what that means is that they are dying at a lower rate. And in fact, people with FH, and we're talking about people that have cholesterol in their 300s or beyond, are dying at about half the rate of the general population of people in their 70s. And that was statistically significant. And this is actually consistent with the general literature. So what is happening with the people in their 70s with extremely high cholesterol that are dying at such a low rate? Well, this paper, which really is one of the best papers if you want to look at general rate of death, they broke it down to the type of death. And the people in their 70s, again, with very high cholesterol, are dying at a normal rate. That's right, they're right around 1.0. And they have half the rate of death from cancer and less than half the rate of death from other causes. Now, is this a mystery? I mean, you read this and say, why aren't these people dying at an extremely high rate? Well, there's an explanation. They're not different from the general population. That in fact, people with high cholesterol, and here's a paper that I had the pleasure to publish along with other investigators, almost all of these being MDs, including cardiologists. And what we found is the people with the highest LDL, which is all the bad cholesterol, they live as long, and even most of the findings show they live longer than people with low LDL. And so that's why the conclusion was that we should question the validity of the cholesterol hypothesis, which is that high cholesterol will clog your arteries and cause premature death. Now, why is that? Why is high cholesterol so good for you? And this is a message that people generally don't hear. But there's an extensive literature showing that not only in general are lipoproteins important for our immune system, but specifically LDL is important for immune function. That bacteria produce toxins that can kill you. For example, when people die of sepsis, it's a result of the toxins produced by bacteria that can ultimately cause the immune system to go on the offensive and destroy our own organs. And so LDL, in fact, binds to these toxins and protects us. So this is something that's entirely ignored by cardiologists and largely unknown by the general population, but very well established in studies of the immune system. And this is, in fact, why elderly people with high LDL are so healthy. Granted, we still need to be concerned about heart disease. So what about people with high cholesterol? Is it the high LDL that is causing more heart disease? So we have really important papers that every now and then are looking beyond LDL and telling us what's actually causing heart disease. So here's a really nice paper on people with familial hypercholesterolemia, meaning of extremely high cholesterol. And they're all on statins, which has now reduced the LDL. As you can see here, we have two groups that are about 150, which is still considered high. But the important thing about this graph is that it shows that we have two groups of people. We have in red those people who have no heart disease, and in blue, those people who have heart disease. And we see they have equivalent LDL levels. So what's the difference between those with heart disease and those without? Well, the crucial difference, and this is a measure that's consistent across the literature, is one of the best measures that one can have to predict 10-year rate of cardiovascular events, and that's coronary calcium. So those people that had extremely high coronary calcium, and that's here in blue, you can see well over 200, those are the people that had coronary events. And what else is consistent with high coronary calcium is high blood sugar, high fasting glucose. Those with coronary events had very high fasting glucose. Those with a low incidence of coronary events had much lower fasting glucose in a very good range. And this is consistent across the literature. And so much in which you fellows, you have talked about is the importance of diabetes as a risk for every Western disease, particularly heart disease. So high blood sugar clearly is one of the most important risk factors for heart disease, clearly just blowing away any potential influence of LDL. And in fact, in this study, which we reviewed in a paper we published in British Medical Journal 4 years ago, this is such an important paper because it's got people, and this is correcting for LDL levels, and it's looking at fasting insulin, and it's looking at people's waist size. These are really two of the most important measures that tell you whether or not someone will have heart disease. And so when you look at the general population of people who have low insulin and are not obese, as your reference, that's the 1.0. When you look at people with high LDL cholesterol, but they have low insulin and low waist size, there's no significant increase in the incidence of coronary artery disease. The people who have high insulin, in particular, high insulin and obesity, have over 7 times the rate of heart disease compared to the general population. So this is just one of the studies we reviewed in this paper, which has open access in BMJ from 2020. And again, it emphasizes the importance of blood sugar as a critical influence as to whether or not someone would develop heart disease. So let's take this a step further. Granted, people with FH do have more heart disease than the general population. So let's look at another study that looked further than just looking at LDL. This is a really very nice study published by a group that's very strong statin advocates. And what they've shown here is that you've got people that have extremely high LDL and total cholesterol. So their LDL is almost 300. Their total cholesterol is over 350. And again, you've got two groups. You've got those diagnosed with Ph.D., which is coronary heart disease, and those without coronary heart disease. And you see there's no difference between those with and without coronary heart disease as far as their total cholesterol and their LDL. There's a slight difference in their HDL and a slight difference in their triglycerides. So lower HDL, higher triglycerides. That's a sign of insulin resistance. But what's most important is when you look at clotting factors. And so there is a genetic predisposition that you find in not only FH, but in the general population, that people who have this, what's called a polymorphism, a gene form for the protein prothrombin, which is involved in clotting. Well, those who have this polymorphism are over 2 times as likely to be diagnosed with coronary heart disease. and that is independent of their LDL. And so this clotting factor is incredibly important. If you've got this polymorphism, you're much more likely to develop heart disease, and it's independent of your LDL levels. Another study, and this is rare because normally people are looking at FH, they only look at cholesterol, but sometimes we have a treat. We get the sort of a present that some investigators, or this is before the development of statins, in which you can look at other factors besides LDL. So here's another study in which you see no difference in total cholesterol, LDL, as well as HDL and triglycerides. And what you find is extremely high total cholesterol, extremely high LDL. This is before the age of statins. And the crucial difference are the clotting factors. So the people who did not have coronary heart disease in blue had a lower level of fibrinogen and factor VIII. So these are the crucial clotting factors that when they become activated, then cause a blockage in our arteries, increase the viscosity of our plasma, and therefore contribute to coronary heart disease. Now, this isn't just a few studies and just not what I present in talks. I've had the great pleasure to work with Drs. Ufi Ravenskov, Dr. Michelle Largeril, and Dr. Malcolm Kendrick, and we have published papers on the importance we called coagulopathy. When you look at the people with FH, that's familial hypercholesterolemia, those are the people who die young, and the people who die old. What is crucial is that they have greater clotting factors, or they have less reduction of clotting, which is called fibrinolysis. So we've got some papers that we have published on this, which frankly, I have to admit, has been ignored by cardiologists, most cardiologists. I will also say that Michel de Largeril is a cardiologist in France, and he recognizes the importance of clotting factors and does not believe that people with FH should automatically be treated with statins because he understands the importance of the clotting factors and not the LDL as a cause of heart disease. So if we look at one of the clotting factors, one of the most important ones is fibrinogen. So this is a protein that in its inactivated state is benign. But when it gets activated, what activates fibrinogen? High blood sugar, high blood pressure, stress, activates fibrinogen, which then triggers a cascade in which we ultimately end up with clots. And when we look here in this study, at whether we're looking coronary heart disease, as well as cerebrovascular disease or stroke, what we see is a linear relation between the amount of fibrinogen in the blood and the risk for heart disease as well as stroke. There is nothing like this kind of clear age-independent risk that you'll find with cholesterol. So what is most important that we need to really be aware of is the clotting factors, because this ultimately is what causes both coronary heart disease as well as stroke. So this is an incredibly important slide because we still need to address, is LDL completely innocent of causing heart disease? And the answer is, well, maybe not. So when the lipoprotein is packaged by the liver, it can be modified depending on someone's metabolism. So in a healthy person with low triglycerides, low blood sugar, high HDL, that person will be producing ultimately an LDL that is really very healthy. That's called the large buoyant LDL, which is not associated with heart disease. But in that person with metabolic syndrome, that person with particularly high blood sugar, what will happen is that glucose will bind to the LDL. And this is the same thing when you're measuring A1C, HbA1c. What you're measuring is the amount of glucose that is bound to your hemoglobin, which then interferes with its functioning. And the same thing happens with LDL. LDL has glucose bound to it. That's called glycation. You have damage to the LDL particle. It's oxidized, it's glycated, which is called glycoxidation, and that interferes with its functioning. It will then remain in the blood much longer than the large buoyant LDL. It will have more difficulty being able to bind to the LDL receptors. It will exist in an unhealthy metabolism. It will exist under conditions in which there is damage to the artery wall. And it gets caught up, in a sense, in this maelstrom of damaged metabolism. And so it becomes a part of the damage in the artery wall, further triggering an immune response. So you not only have inflammation, you have damage to the artery wall caused by the hypertension and the hyperglycemia. And you then find, in some cases, an association of this form of LDL with heart disease. So I really want to emphasize the small, dense LDL does not exist on its own. It is always found in an individual that has a damaged metabolism, and it potentially now is contributing to the damage. It is, in a sense, like you already have a burning building. And you've got the LDL that is often compared to the firefighters, which is really quite valid to say the LDL is looking to repair the tissue. But in a sense, to take that metaphor a little further, the small, dense LDL is like a firefighter that's coming to fight the fire, but he's brought gasoline with him. And so potentially exacerbating the problem. And it is really important, again, I want to emphasize the small, dense LDL does not exist to a high degree in a healthy person. So let's look at the small, dense LDL, which again is what you find in people with typically high blood sugar, high triglycerides. So if we look at people who have a high level of small, dense LDL versus those who have a low level small, dense LDL, those people who are in the upper half having high, small, dense LDL, they also are extremely high in triglycerides, which is unhealthy. And this is what I learned for myself, that I had extremely high triglycerides, which I didn't mention earlier in the introduction. As a result of my studying the literature, realized that what was causing my high triglycerides was my excess consumption of carbohydrates. And so by dramatically reducing my carbohydrate consumption, I've been able to lose weight, reduce my triglycerides by about 75%, and also raise my HDL by about 25%. So in the last 25 years, I've been able to improve my overall metabolism. So let's get back to this study. So what you've got here is people who have a high degree of small, dense LDL, have very high triglycerides. People who are very low in small, dense LDL have a very healthy level of triglycerides. Looking at these people as well, the people with high, small, dense LDL, over 70% of them are diagnosed with metabolic syndrome, which means high triglycerides, high blood sugar, high blood pressure. So these people are very unhealthy. So the small, dense LDL exists in an unhealthy metabolism. Now let's look at their rate of heart attacks, coronary heart disease. The people who have the high level of small, dense LDL have far greater incidence of coronary heart disease compared to those who are very low in the small dense LDL. So this is a risk factor for heart disease, but it's an indication, again, that someone is very unhealthy. You look at the native LDL, the one that is not damaged by blood sugar, and that's the large buoyant LDL, and that's on the right. And what you see is no association of large buoyant LDL to heart disease risk, because large buoyant LDL has not been damaged by the blood sugar. Now, there's an odd finding that people with familial hypercholesterolemia do not have more strokes than the general population. And one reason for that is you actually do find that people with FH are relatively healthy. Obesity is rare. Diabetes, type 2 diabetes is rare. And so they rarely have high blood sugar. And so one question is, why is it that people with high cholesterol in general don't have a greater incidence of stroke? Well, again, it's because high cholesterol is not blocking arteries. So what is it that causes stroke? Well, it's very clear. What causes a stroke is blood clots. And so this slide right here shows the association of small dense LDL with a greater incidence of stroke. And why is that? Well, again, small dense LDL exists in a metabolism that is dominated by high blood sugar. And so the people who have the highest incidence of small dense LDL are also the ones that have more stroke. So again, I emphasize, because one component of LDL is associated with, in this case, cerebrovascular disease, does not mean it alone is causing it. We need to look at what is causing an increased incidence and concentration of small dense LDL. And what is causing that is the increased blood sugar you find in these people. So let's take this a step further. LDL-C, so often people just measure their LDL-C, and the LDL-C is high, and your blood test result says you should go on a statin. Your doctor is alarmed because your LDL-C is 200 or 300. We need to understand, LDL-C is a terrible measure because it has multiple components. So when you get an LDL-C measure, that is a combination of the small dense LDL and the large buoyant LDL. So first of all, realize you need to know, of course, you need to know your blood pressure and your blood sugar, but you're seeing a hybrid measure. It's not telling you the relative difference between the small dense and the large buoyant LDL. It's just looking at the total LDL in all the particles. So that's the first thing that's a problem. Now, I hope you can see this animation in which the studies are so consistent. And I've enjoyed hearing the talk before mine on the importance of blood sugar, to reduce blood sugar with a low carb or ketogenic diet. Because what happens with the low carb diet is that because the blood sugar comes down, you're reducing the small dense LDL, you're increasing the large buoyant LDL. Now, what can happen? What can happen is that your large buoyant LDL potentially now is transporting a large amount of the fat that's being metabolized. So if your large buoyant LDL goes up a lot and your small dense goes down, your total LDL-C could actually grow, could be very large. But of course, that doesn't tell you really about your risk. Your risk ultimately gets to, again, blood sugar and the small dense LDL, which has dropped. And we reviewed these findings 4 years ago, working with doctors Blair O'Neill and Jeff Bollock. And if you look at where these arrows are pointing, what we showed in reviewing the literature is that large buoyant LDL, that is, of course, the one that at worst is neutral and at best is helping your immune system. But there's a significant increase in large buoyant concentration in people on the low carb diet, compared especially to the low fat diet. And now if we look on the right, we see all these measures in which it's better when they go down. And in particular, we focus right now, the small dense LDL, here you can see in blue, is declining. All these other measures, the weight, blood glucose, insulin, the measure of insulin resistance, the HOMA, triglycerides drop dramatically. The ratio of triglyceride to HDL, the small dense LDL has dropped, leptin as well, and LP little a, which is also a measure. So all these measures, all these risk factors have improved. So there's certainly no reason. And you see on the far left, the LDL-C may increase, but there's certainly no reason to fear high LDL-C for someone on a low carb diet. Let's take this another step further, just to show you the, frankly, absurdity of depending on LDL-C as a determinant as to whether or not someone is at risk for heart disease. There is another lipoprotein which is structurally almost identical to LDL, and that's lipoprotein A, or called LP little a. Even though it is virtually identical, it has quite different function from LDL. And the reason why it's all together is because when you measure LDL-C, you're looking at LP little a as well, because it is structurally so similar to LDL. LP little a does not actually cause clotting. LP little a is involved potentially in reducing fibrinolysis. And so what you've got is LP little a can interfere with the breakdown of clots. And so what you've got then is LP little a is bound to the clots and interferes with this fibrinolysis process. And I think we're only learning the importance of LP little a, but what is very clear is that there is evidence that high LP little a is associated with an increased incidence of heart disease. And so high incidence or high concentration of LP little a will drive up your LDL-C measure, but it's measuring something completely different. And what's important about this paper that I have is that these investigators were able to tease out the component of LDL-C, which was the LP little a. And their conclusion was that LDL-C, which again, remember, is this global measure, multiple ingredients. When they removed the LP little a component, then LDL-C was no longer associated with heart disease. This is an incredibly important finding that says that LDL-C is useless. People shouldn't be paying attention to LDL-C because it has individual components that are either neutral, such as large buoyant LDL, or the small dense LDL, which is basically damaged LDL from blood sugar, or the lipoprotein A, which is somehow involved in fibrinolysis, which ultimately means, again, getting back to clotting. If you're interfering with fibrinolysis, well, then you're going to have more clots that will be presented for a longer period of time. Okay, so now let's talk about statins. Of course, statins are the wonder drugs. This is the go-to drug for anybody that's at risk of heart disease. Even if you don't have high cholesterol, people are recommended to take statins for secondary prevention or if they have diabetes. And here is an ad for Crestor. This was work that actually got Crestor approved by the FDA. Huge benefit of giving patients Crestor. And so this seems to be completely contrary to what I've been talking about, because statins, as a result of blocking HMG-CoA reductase, the enzyme ultimately involved in producing cholesterol, dramatically reduce the incidence of heart attacks, here by 54%. So let's actually look at how this is presented. So this is when I took a CME course to see how this work is presented. So rosuvastatin, the term specifically for Crestor. And you see on this graph, which appears very impressive, is that there is this reduction in the incidence of coronary events with rosuvastatin. So let's look a little further at the raw data. This is what I've been doing with all of the statin trials. Let's look a little further. Okay. So, and I want to show you how is this presented in the medical literature. The numbers are very impressive. Here's the 44% in all events. The largest effect was a 54% reduction in myocardial infarction, meaning 54% reduction in heart attacks. Okay. So let's set that aside and keep that in mind. And let's actually look at what is that 54%, because it seems like half of all people who take a statin will not have a heart attack. So I have shown here on the left the same way to present the data, but what I'm showing you here is the percent of people that did not have a heart attack. And I hope this little guy is shown up on your screen. The difference between those treated with Crestor and those treated with placebo is 54%. And again, just to be clear, we are looking at the percent of people that did not have a heart attack. And that difference between the blue and the red is 54%. And it was this finding that got Crestor approved by the FDA in about 2009. How can that be a 54% reduction? Because over 99% of all subjects did not have a heart attack. Let's look at the raw data. For those on Crestor, we had almost 9,000 people in this study. About 8901 in a Crestor, 8901. 31 people had a heart attack in the Crestor group, 68 people in the placebo group. So almost 18,000 people, less than 100, had a heart attack. I like to say these people are horribly uncooperative. Almost nobody had a heart attack. Almost nobody died. So let's get to the numbers. How is there a 54% reduction in heart attacks? So the arithmetic difference between the placebo and the Crestor group was 0.41%. And 0.41% is 54% of 0.76. This is so important. We need to understand how you can take statistics and manipulate it in a way. I mean, why was it Paul Ridker, Dr. Ridker, didn't say the real difference was 0.41, instead is using 54%. This is routinely done, and we have published a paper on this. This has been done for 40 years. This is taking the real difference, which is the absolute risk difference, and amplifying it, which is called the relative risk difference. And it gives you the impression that you're so incredibly safe by taking the statin, when actually statins are incredibly inept, effectively impotent at really making a substantial difference in the incidence of heart disease. And in fact, based on this study, you'd have to give Crestor to over 200 people, 220 people, to stop one heart attack from occurring in one person. So instead of saying, wow, I've lowered my heart attack risk by 54%, the real finding is I've lowered my risk of a heart attack by 0.41%. Over 99% of the people on Crestor will have no different outcome compared to those on placebo. And this has actually been quantified. And again, it's not just something I present in meetings. We have published on this. Here is a very nice review and meta-analysis published in JAMA, in which the arrows are pointing to the incredibly low benefit of statins. And that's the absolute risk reduction, which is around 1% overall, which can be amplified by relative risk. But this is not what you should be using. You really want to look at the absolute risk reduction. What's the actual chance that I'm not going to have a heart attack? And that's typically 1% or less. And the authors of this study basically were very straightforward, saying benefits are modest. Most participants who took the statins, and this is under ideal conditions, by the way, in typically drug company funded studies, most participants derive no clinical benefit. And why is it there's even a small benefit of statins? Well, this is a paper from over 2 decades ago, and it's been known for over 2 decades. That in fact, and like right here underlined in red, that in fact LDL cholesterol levels are weakly associated with cardiovascular events. So what's a real benefit of statins? Non-lipid mechanisms, reducing thrombus formation. What's going on with a thrombus? It's clotting. And so statins can reduce some clots. So again, we get back to clots as the real trigger for producing cardiovascular disease. And ultimately, this is the cause of why it is people have heart disease and cerebrovascular disease. What we want to do is minimize that clotting. So 1%, it's better than nothing. But we have seen adverse effects. And in fact, and I see we're probably getting a little light on time, so perhaps you want me to move along. But one of which is forgetfulness, okay? Cognitive impairment mentioned by the AHA. And so what we have is dementia. Here reported in the study on elderly people on statins. They were taken off their statins, cognition improved. They're put back on the statins, once again, diagnosed with dementia. In addition, you see a doubling in the rate of diabetes in people on statins. Multiple studies have shown adverse effects of statins in people: kidney disease, muscle atrophy, reduction in sex steroids. Here are more papers, which I would, if I had more time, I would go into it. We reviewed this in a paper we published a couple of years ago on why statin therapy is not warranted for a person on a low carbohydrate diet. Let me finish by saying, well, what about if you've got low triglycerides and high HDL? So here you've got people with high triglycerides, low HDL. These people are unhealthy. The simvastatin did reduce events in these people who are unhealthy, largely because it's blocking clotting. But now look at the people with low triglycerides and high HDL. These people by themselves, the placebo group, has a low incidence of heart disease. So this is what's crucial. The simvastatin had no benefit in the people that had low triglycerides and high HDL. So therefore, the statins have a benefit only in those who are unwell. Finally, this is what's wrong with the way people think about LDL. This diagram just shows LDL getting into the artery and causing damage. What they're not taking into account is what's called the glycocalyx. This is a protective barrier that we have on our artery wall. And it stops blood cells, it stops clotting, and it stops LDL from getting into the artery. This is an image of the glycocalyx. What you see on the right is the glycocalyx is damaged by high blood sugar. And then you have calcium accumulation, platelets aggregate as a result of the damage from high blood sugar and high blood pressure. And in fact, the people who have damage to their glycocalyx here on the bottom, they are the first to show increased heart disease. Okay, that's the PBR 525. These are the people who have damage to their glycocalyx. These are the people who then develop the heart disease first. So then, in conclusion, we published this paper a couple of years ago, very controversial. We reviewed all the evidence on the benefits of the low carbohydrate diet. The only concern with low carbohydrate diet is you can raise LDL-C. And I've tried to present in this short period of time where you do not need to be concerned about high LDL-C alone. And I have chapters in these books, and there are so many people that I have benefited from. And many of them are in have written chapters in these books that I highly recommend to people. And I thank you.
Thank you, David. I think that was very interesting, and especially the low carb community is always worried about the rise in cholesterol which we see, or rise in LDL which we see, and I think this gradual, right from the beginning to the conclusion, I think you have made it amply clear that in the light of so many other positive things, that one small rise in LDL, maybe it is rather not at all atherogenic or not at all concerned when we have so many. And amply you have demonstrated that blood sugar seems to be an issue with everything, including the clotting factor of fibrinogen, which I think usually is not talked about or measured also. And I don't even know if any laboratory in India measures fibrinogen. So such is the state. So thank you very much. It was very insightful. Anup.
It's a pleasure to share with you. Thank you so much for inviting me again, Shashi and Anup. I wish you both well.
Thank you, Dr. David. Finally, we have had a session with you.
Yeah, thanks, Dr. David, and maybe we'll meet again in future events. Probably when little more other data also comes, because I see that there are continuous publications on this cholesterol front, especially in the low carb ketogenic front. So a lot of things are emerging now. So probably we'll be able to discuss much more things which are already happening in this front, maybe in the future events.
And we have a paper just about to come out as well in Frontiers on this topic as well. And I look forward to meeting you someday in person.
Thank you.